Hi, welcome to This Week in Psychiatric Nursing from PsychWise. I'm Cassie Powers, and today is July 19th, 2026. First, I'd like to talk about a study that takes a look at IM ketamine compared to intranasal ketamine. After that, I'd like to look at a recent FDA clearance for a brain function measurement device. In conjunction with that, let's analyze two editorials that raise questions about the FDA approval process. And finally, let's put a spotlight on Penn Medicine's treatment model for mental health crisis care. So what is This Week in Psychiatric Nursing? If you're new here, I'm Cassie. I'm a psychiatric nurse practitioner in Portland, Maine. I've been doing this for about 14 years. I also teach in a BSN and MSN program. I do this because I want to bring you a brief summary of news, policy updates, and research findings that affect the work we do in behavioral health nursing. I use reputable sources, and I keep you abreast of developments that affect your practice all in 10 minutes or less. Quick reminder, this video is for educational purposes only. It's not medical advice. All right, let's dive into the research on ketamine, comparing ketamine formulations. This was a study that came out of a VA medical center, a retrospective observational cohort study. And what it found was that IM ketamine, which is much cheaper than intranasal ketamine, is not any worse from intranasal. So they're comparable treatments, and they don't create different safety profiles. So this is important for psych nurses because treatment-resistant depression can lead to such significant functional impairment, including risk of suicide and a rise in all-cause mortality, especially among a veteran population. So psychiatric clinics are particularly well suited to administer injectable medications. This is one of the common places where behavioral health nurses already work, and they have the skills necessary to provide this treatment. IM ketamine could be a potentially more cost-effective option for delivering this type of treatment. Unfortunately, we don't have a lot of high-quality comparative studies, which leads to kind of a critical evidence gap, and that may prevent a more widespread adoption of IM ketamine therapy. And I'd like to note that the study here, one limitation is that it was on a VA population, so this was not a general population. Next, I'd like to look at the recent FDA approval of a medical device that records the brain's electrical activity. This is a novel technology, and it touts objective brain function measurement. The FDA granted 510(k) clearance for Universal Brain's proprietary system. What does this device do? It measures brain function using EEG, not a new technology. What's new here is the speed with which they do it. It's a form of precision psychiatry. So it provides very rapid measurement of brain function in both clinical practice and clinical trials, as opposed to other types of EEG measurement, which are not rapid. So some limitations here. Universal Brain aims to make this a rapid and reliable functional assessment routine, but it is a for-profit company. So will this be yet another treatment model that is out of reach for most of the population because of cost? We don't know. Also, at best, this device could support with decision-making for psychiatric treatment, but there is no evidence yet that it actually improves patient outcomes. So what are the implications here for psych nurses? Psychiatry has few objective tools available to measure the underlying biology of mental illness. So this is one potential advancement in that area. Most of psychiatry relies on subjective reporting from the patient, and in theory, objective observation of the nurse and/or provider, but that observation has a subjective element to it. You can have two different opinions between two different observers. Let's look at how the FDA approves new devices or drugs. Two opinion pieces came out recently that take a look at this. The first one is from the Journal of American Medical Association, and it states that sometimes the FDA exercises what they call regulatory flexibility to focus on statistical as opposed to clinical significance in a few trials, allowing the approval of drugs with scant benefits. Another author, Peter Simons at Mad in America, echoed these concerns, asking why the FDA continues to approve drugs that fail to show efficacy in the majority of their trials. So these authors are advocating for a more transparent labeling and reporting process for all high-quality trials, regardless of outcome. So if the trial shows positive outcomes, they want reporting, and if the trial shows negative outcomes, they also want the reporting on that. Implications here for psych nurses are that the public's perception and the perception of medical personnel may be more favorable to the FDA than is warranted. So these authors argue that the FDA approval process warrants more scrutiny and that it may not always point to safety and efficacy quality evidence that people would assume of it. So these are opinion pieces. These are not studies. Finally, I'd like to take a look at Penn Medicine's approach to mental health crisis care. So this model is a 24/7 walk-in setting built specifically for rapid psychiatric assessment, stabilization, and connection to ongoing support. This is meaningful because so much mental health crisis care goes on in emergency rooms now. They are playing this role. They've become the entry point for mental health crisis, even though the design and staffing and model may not be the best for that. Studies show that up to a fifth of psych ED visits result in boarding, which can delay treatment and make symptoms worse. This model can actually reduce the load on emergency rooms, which means those resources are more available for acute medical needs, and the people in psychiatric crisis are actually getting a more specialized form of care that they wouldn't necessarily receive at an emergency room. So the CRC in Philadelphia includes intentional design choices of the space so that they are most helpful to people in a psychiatric crisis. Just one example is the nurses' station, which has open sightlines that support visibility and de-escalation. Key takeaways from this week in psychiatric nursing: ketamine is cheaper and it's not inferior to intranasal. FDA approval processes may not be what you think, but there is a new recent approval for a precision psychiatry device measuring brain function. And we took a look at a promising model for mental health crisis treatment in Philadelphia. That is it for this week in psychiatric nursing. I'm Cassie Powers. Thanks for tuning in. As always, please feel free to leave a comment or a question, especially if there's a topic you would like me to take a look at next week.